Yeah, please. Check F2 on. Good afternoon, everyone, and a very warm welcome to all present here. We are delighted to have you with us for the symposium titled Psychotherapy for NSSI Among Adolescents Evidence Based Practice from India. First, I would like to call our chairperson, Dr. Ashima Nehra, ma'am. Ma'am is currently a professor of clinical psychology at the Neuroscience Center, AIMS, New Delhi, with over 3 decades of experience in teaching, research, and clinical work. Dr. Nehra is leading figure in the field of clinical neuropsychology. Her work focuses on the neuropsychological continuum of care for neurological conditions, combining scientific rigor with compassionate clinical practice. She has an outstanding academic and research profile with more than 200 index publications, 12 randomized control trials, and numerous national and international presentations. Ma'am has also guided many doctoral and postdoctoral scholars and contributed extensively to national level health initiatives and professional guidelines. Welcome, ma'am. I would like to call Ms. Rashmi Pandey to felicitate our chairperson, Dr. Ashima Nehra, ma'am. Yes, ma'am. Thank you. We are privileged to have with us a panel of insightful speakers who will be sharing their perspective on this important theme. NSSI is emerging as a significant mental health concern among young people, one that calls for sensitive, evidence informed, and culturally grounded approaches. This symposium brings together research and clinical insights from the Indian context, highlighting how psychotherapy can be effectively tailored to address the unique development and cultural needs of adolescents. We look forward to an enlightening discussion that bridges research, clinical practice, and the realities of youth. Our first speaker of the day is Dr. B.N. Rupesh. He is an additional professor of clinical psychology at NIMHANS, Bangalore. Dr. Rupesh brings rich expertise in child and adolescent mental health and psychological assessment with years of experience in both clinical work and research. He has been recognized as a top reviewer by Elsevier, and his publications has ranked among the most read by an author from NIMHANS on ResearchGate. Please, sir, come to the stage.
May I also request the other presenters also to come up on the dais, please?
Yes, please come. Then I will introduce. Our next speaker, Professor Dr. Thomas Kishore. He is currently a professor in the Department of Clinical Psychology at NIMHANS, Bangalore. His work over the years has significantly advanced the field of child and adolescent mental health. He is also a recipient of the ISCP Oration Award and the Rita Peshwaria Fellowship and Oration for his pioneering research in autism spectrum disorders. Our third speaker, Dr. Oshin Saxena. She is a RCI licensed clinical psychologist and research scientist at AIMS, New Delhi. She holds an MPhil in clinical psychology from GMCH and PhD in clinical psychology from NIMHANS, Bangalore. Her areas of expertise include psychotherapy, group therapy, adolescent mental health, dissociation, and SSI. She has also worked as a senior research fellow at AIMS, contributing to evidence based intervention and mental health research. I welcome you all, the speakers and the chairperson, and I would like to request our chairperson to felicitate our speakers. Please, ma'am. Sir, we will start with you first, the felicitation. Please, sir, come. Give it to ma'am. Professor Dr. Thomas Kishore, sir. Dr. Oshin Saxena. With this note, we would like to start our session. Okay. Program. Yes, ma'am. I'll call you later. I'll call you बाद में call करूँ. Sorry. Sorry. Yeah, I just want to know exactly in 7 minutes is the time or what? Any idea? Okay. So it's about 15 minutes. So
May I call Dr. B.N. Rupesh to kindly deliver his talk? Thank you. So the time, as they're stating, is about 15 minutes. And so we'll try and finish it in that much time so that we have enough time for interaction with the audience. Thank you.
Okay, start my time. 15 minutes. Okay, good afternoon. So we'll be presenting about NSSI. Uh, so the reason for this symposium is, I think most of you probably will know now, like incidence of non-suicidal self injury is increasing. So again, there's a debate about really increasing, or we're coming to know more about it, recognizing more, diagnosing more, or it's increasing. So through the presentation, like we'll go through it. So yeah. Again, the like seminal paper Kessel in 1965 mentions that not all self-injuries are suicidal. Okay, earlier it was thought like, okay, any parasuicide, even some like high risk activities, people go fast in their bike, do any other jumping and other things, we can consider as their parasuicide. They're committing, like, starting from like Freudian psychodynamic on this specs. But again, he says that it's not true. So if you consider everything as suicide, as some aspect of suicide, you're missing out major things. So that's first thing. Apart from that, like later on, people came up with different in terms of parasuicide, self-mutilation, all different things. And this closely related word is few years back, people used to use deliberate self-harm. I think most of you would have studied in your bachelor's, master's. We studied like when we did, we didn't have NSSI. It was deliberate self-harm. So small difference between deliberate self-harm to NSSI, non-suicidal self-injury is, for example, deliberate self-harm, for example, drug overdose can become. Okay. So deliberate self-harm can, for example, drug overdose can be considered deliberate self-harm compared to non-suicidal self-injury. Okay. In drug overdose, there is no injury to the tissue. That's a small thing, the difference there, some example. Okay, the International Society for Self-Injury defines NSSI as deliberate self-inflicted destruction of body tissue that is not socially sanctioned and there is no suicidal intent. So these are the come of things. So important thing is purposeful. If you look at it, directly damages the tissue. It can be soft tissue or hard tissue. Then it excludes the self-injurious behaviors like eating disorder, substance abuse, those aspects. Again, does not include beautification, religious and culture, tattoos and piercing does not include. Again, non-suicidal reasons. So it's quite obvious. So what are the different types of injuries or like in SSI? One is cutting, shallow cutting, again, carving, scratching or rubbing skin, burning, banging, punching, hitting, or biting oneself. Again, inserting, poking sharp objects onto oneself. Again, picking wounds, like picking wounds. That also can be considered. Some people might perceive it as necessary, or it can also be considered as like normal behavior sometimes without people knowing. Like there's no purposeful thing, it's not deliberate. Even though they're not doing, there's no intention to harm there. Again, in terms of severity, mild to moderate can increase, not severe cases. Again, not potentially life-threatening. In terms of frequency, it can be situational, it can be occasional, or it can be frequent, or it can go into episodic aspect. Types, planned or unplanned. So this part. Am I going fast or fine? Okay. So in terms of epidemiology, it varies depending on the definition used and where they have conducted that as again. So for adults, it's about 3%, but in case of adolescents, college students, lifetime prevalence is, if you look at it, 46%. Adolescents about 30 for about 40% for college students. Again, different studies there. So this study has showed that based on 27 studies, average they have taken about 18% lifetime prevalence of NSSI, which is quite huge. Again, high school students about 24%, but they consider the frequent use of frequent NSSI, it comes down to 5%. So it's more frequent is very less, but non-frequent is more. Gender, again, like equivocal results. Some say more in female, some say it's not. There's no significant difference. So there's equivocal results. But in terms of like clinical samples, so there's females are more. For example, clinical sample is like with mental disorder, the females significantly more than the males. Again, in terms of racial or ethnicity difference, Asian students, again, is a US study. Asian students compared to white Americans. So Asian students have significantly less non-suicide in SSI. In terms of statistics, again, more clinical sample with comorbid conditions, with especially emotional disorder is shown to be more. Higher NSSI with less number of peers and being alone correlates. More peer victimization, higher NSSI. Again, multiple types of NSSI, more serious issues and more chance of suicide. Again, suicide about 35 to 40% increase. NSSI can predict the suicide if they're frequent. Increasing trend I was talking about, again, no conclusive evidence, depending on the studies, it varies. But one study, relatively recent study mentioned that in lifetime, they've studied longitudinal, like 2008, 11, and 15. You can see that 16, 28, and 45. Again, is the past 90 days when they're interviewed, that's the part. So again, I'll skip this because time issues. Some research findings, if you look at the one very long study, 1,267 patients, cutting skin is almost 94%. Scratching is prevalence, this part. So now same thing it matched with our study also, 96% cutting and hitting 53 and pulling hair about this. But ours is a small sample size 30. In terms of function of NSSI, so it serves a different function. So in terms of interpersonal, intrapersonal, so one major thing is affect regulation to decrease negative like emotions and also to increase some of the positive aspect of it. Again, to avoid dissociation, so to feel real, to feel alive, self-punishment for guilt and self-hate, distraction from like undesirable thoughts or unwanted thoughts, again to avoid suicide. So these are the intrapersonal one. Interpersonal is to communicate distress, seeking help, to influence others, to obtain something, for example, care, or to solve some problem, marital issues, problems. Again, to gain autonomy or regain autonomy and control. Then again, as a mark of belongingness, mutual agreement. Sometimes we find like we work in a setting where there'll be a couple of adolescents, so they'll form a team, WhatsApp group or Instagram is aspect. So they all they all decide, okay, I'll cut now. Okay, they'll mutually decide to cut each other's. So they like after discharge also they continue the group. They'll comment about, okay, I cut today. Like how many times you cut today. So in terms of mutual agreement, that's there. Apart from other functions, what we found out, we've again one of our published papers, whatever is mentioned apart from it, there is impulsive, addictive, and compulsive elements also there. Impulsive, most of us know immediate without thinking. Like addictive, it becomes an addiction. They continue to do it. If it's not done, they'll crave it. Like there's a craving. They're always thinking about it. I have to do. Okay, as soon as they get up, that I have to do. So it becomes a craving. So it's almost like an addiction kind one. Next is compulsion. So when they don't do it, they miss on that. They have to do it. Something the compulsive element also there. So these are the other aspects of the thing. In terms of causes, risk factors. Okay. So in terms of neurobiological aspect, people with NSSI, they've shown that the pain threshold has increased. Like their pain threshold is higher. So that part. So that's why the pain threshold is higher. So they don't get so much of, for example, pain when they're doing it. Again, in terms of when they stop NSSI, the pain threshold returns to normal. Again, you have to remember that some of us have some amount of, most of us, I think, would have been used to it. Sometimes we pick wounds, even though I can say a form of self-harm. Like we get positive. Most of you know that we get some positive feeling, we like that small kind of feeling. So like neurotransmitter releasing small kind of wound. It actually like kind of reinforced. Like we like it. So that aspect. Again, it's very hot water bath. So some of us are used to it. So these kind of aspects. Again, opioids, pain perception. They go like opioid receptors are altered in patients with a history of NSSI. So again, like higher activation amygdala and anterior cingulate cortex when viewing emotional pictures. So after application of pain, this like higher activation amygdala and anterior cingulate cortex decrease. Studies have shown that decreases. So that aspect. Again, compared to controls, mood and body awareness increases. For example, research has shown that, for example, if you put like hand, like something called cold pressure test. So you put your hand in the ice, so it sometimes starts paining. So people have put it, then they start feeling mood and body awareness increased. So that's again going into terms of anti-dissociation function. That aspect for people who are doing it to feel alive and avoid being numb. So for them, it like to shown results. Again, NSSI correlates with like hyper-responsive HPA axis. That is, the response is higher for the stress, like lower for the stress. So I think to compensate, some of the NSSI is continued. In terms of Psychological, one is very well more the common form aspect is like emotional regulation issues or emotional dysregulation, like inability to alter the emotional response, being stuck in a negative situation. Next is high emotional reactivity. The emotional reaction is very fast. Shown. Again, negative urgency. So negative urgency in a sense, again, is being impulsive. So they become impulsive for negative emotions. They react any negative emotions, they react very like impulsively. This one of the thing is majorly seen. These three are majorly seen. Again, low self-esteem is seen in most of the NSSI. Low self-esteem. Again, low self-concept was quite seen. Loneliness, one of the other aspect. Hopelessness can be seen. Again, cognitive distortion, because again related to self-criticisms. I deserve this pain. This is the only way to cope. There's no other way. So these are the cognitive distortions what leads them. Again, comorbid mental health issues, automatically depression, anxiety. This all seen with NSSI. When comorbidity is there, the NSSI is seen to be very high. Again, with neurodevelopment disorders, where ADHD, ASD, emotional regulations are considered to be low in these conditions. In terms of interpersonal, social, environmental, main thing is already sees like almost close to BPD, like borderline personality cases, UPD thing, like invalidating environment at home. Then again, attachment issues with the family or primary caretaker, low perceived social support, family conflict, especially like neglect aspects. Is like adverse childhood experiences, again, history of abuse, sexual, emotional abuse. Bullying is considered to be one of the significant risk factor. Again, peer issues, peer rejection, again, peer involved in NSSI, contract, which already mentioned about contract in the peer group, social cognitions, online, copycat, like copycat suicide as copycat NSSI, lack of access to help, coping or therapy resources. Again, in terms of putting all together, a few models. Again, Nook's four-function model. If you look at it, this again, things negative, positive, automatic or intrapersonal, social, interpersonal aspects. So what is this intrapersonal? Negative aspect, to stop bad feelings, to escape feeling numb. So certain aspects, emotion, they want to control it. When they do NSSI, this bad feeling stops. So that aspect. Again, next is automatic intrapersonally to punish positive aspect, to punish oneself to feel relaxed. So NSSI these are the different reasons NSSI is there, not only one reason. So it's like both positive reinforcement, negative reinforcement, like that. So again, it's in terms of the personal or social. So that aspect. Again, in terms of social, to avoid something unpleasant, for example, going to school, or to avoid being with people. So for example, again, the positive is to get some attention, social attention, and to get people to change, maybe a friend, relative, parents relationship to change. So this is the four function model. It's almost similar to the risk factors, if you can see that's one. Next is in terms of Linehan's biosocial emotional dysregulation model. I think most of the models that talk about emotional dysregulation is on the primary aspect of it. Biological vulnerability, and this is almost borrowed from DBT research in adults, is because again DBT and NSSI share quite a bit of risk factors. Biological vulnerability, high emotion sensitivity leads to interacts with invalidating like early and like development environment at home. For example, punishment or neglect of emotional experience that will lead to emotional dysregulation and coping skills. That is, children, for example, children learn how to cope, emotionally regulate by seeing the parents. When something happens and how parents react. It's similar to attachment issues. How parent react, children learn like looking at them and again being developed at them. And because when children have vulnerability and the parents don't respond adequately, either neglect or over criticality, so children don't learn how to regulate their emotions. So that because they're not learning, the parents are not showing how to do it. So that will lead to later on like emotional dysregulation and poor coping skills. Because of this, NSSI functions as a maladaptive coping skills or coping behavior. In terms of my last one, in terms of the criteria to diagnose, it's not a diagnosis yet. However, DSM-5 considered as conditions for further study, puts us under that future you might have NSSI as its own diagnosis, but they consider this to guide the research in this area, to increase the research. Again, in terms of they get 5 criteria, A, B, C, D, E. One is behavioral frequency. I'm not going to detail about it. So like how to uh, almost 1 minute, like done. So I'll finish in 30 seconds. Yeah, finish. So five or more times in last past year. Again, should then exercise the belief that it will solve some problem. Again, one or more experiences. Again, interpersonal problems or negative thoughts. Again, clinical significance causes clinically significant distress and interfere with across different domains. Again, exclusion. So again, it should not be as the result of psychosis, delirium, those aspects. And again, it should not be socially considered, like tattoos or piercings. These some of the 5 criteria. So this I've done with my thing. Like I'll hand over to my
Thank you so much,
colleague.
Dr. Rupesh. I want you to put your thoughts together and have your questions ready. We will try and take all the questions at the end. Is that okay? Dr. Thomas, please. Any question while he's setting it up? Any question that you have? Any thought that you'd like to share? Please.
Sir, thank you for the presentation. It was very crisp and precise. I was just wondering about the part where you mentioned something about peer victimization leading to increase in NSSI behavior. If you could elaborate on it.
For example, in class, the question. Right? So peer victimization is group, like whom you want, who you associate with and who are you want to associate with also. For example, it can be your small clique or 2, 3 friends or in a classroom or a little bit larger as a group, batches. So in that way, what happens, sometimes the dynamics will be there. Cliques or dynamics. For example, one group forms and one person is not so much into it. So there can be a small amount of bullying or you don't know that. Or something they decide and don't tell this person. For example, they go to sometimes you've seen like the group is there, like 5 people, 4 people decide to go to the movie and another person they don't involve. Or any such small thing, or even a bigger thing also, so like spreading rumors, bullying. So all those things it can be considered as peer victimization. Now, school level, college level, any group. It can be any group. It can be like real group also and want to associate with group also in that way. For example, I'm joining this particular college or workplace and I started associating, okay, these are my peers. So in that way, anything can happen. So basically a group, age group or around relatively in terms of 1 or 2 years of age group.
Thank you so much. If there are any more questions, we can take it at the end. I think it's almost set. You ready? So is that okay? Can we take this question at the end? Yeah. Although even I have one question, Dr. Rupesh. Yeah, I'll ask at the end. While they're setting it up, my question, of course, is I want to know between the two genders, the male or the female, who has, as per the research, been performing this act more, males or females? Because suicide is considered to be completed suicide more by men, and attempt is more by women.
Yeah, this is a good question. So in terms of suicide, ma'am is asking. Okay, fine. Thank you. Okay, suicide is, for example, if you look at the attempts are considered by more attempts by women, but in terms of completed suicide is more by men. So again, is many reasons. Earlier, people used to attribute women attention seeking. So they're not serious enough. They just want to scare people, and which is not true, because as a personality, as a social development, women doesn't usually doesn't resort to serious kind of attempts compared to like jumping or guns. So because again, availability, for example, guns compared to men, women hold less guns. Again, have less guns compared to men. So men resort to a serious kind of attempts, like where the chance of escape is very less. So in that way, so sometimes if you ask Even, for example, thinking in terms of how to commit suicide also personality influences. Because you don't sometimes, oh, very harsh. Okay, for example, men doesn't care. Then simple thing, then not jumping something. So that is the reason where you see more completed suicides in men compared to women. So again, it's like, for example, taking tablets. Men resort to jumping, shooting. Women usually resort to taking like overdosing themselves. The chance of survival is more in this. That's the difference.
Good
We'll take
afternoon
your
to
question
everyone.
at the end. Is that okay?
Respected chair and
Hold your thought.
respected chair, my colleagues, and very good afternoon to everyone. After a very elucided presentation by my colleague, I'm going to talk about psychotherapy. That we have understood what NSSI is, how to understand how lethal it is, how common it is. Then, as mental health professionals, what is our role and responsibilities, how we are going to manage it. Okay. Briefly, in this talk, I'm going to touch upon 4 components. That is, what is the lethality? Explanatory model, Dr. Rupesh has very clearly elucidated. So I'll just be very briefly touching as per the need. Implications for psychotherapy, what is the evidence-based practice that is available, what inferences we can draw from that, and the basic conclusion. Though in the literature we see NSSI somewhere in the continuum of deliberate self-harm to suicide, it is there, it shares a strong relationship between, and clinically sometimes it's very difficult to differentiate something that has suicidal intent or not. Because by definition, we know as professionals, NSSI does not involve suicide intention, but on the contrary, in ground reality, it is very difficult to say. Joiner's interpersonal theory says that as a habituation to pain goes up and the perceived burdensomeness and incompetence also increases, and the thwarted belongingness to society or the situation as an increase from unintended self-injury to suicide is quite likely, and somewhere we see NSSI. As again, my colleague has said that we need to understand it from a biological, psychological, and social factors. And the biological factor, age is for all the cognitive changes, neurobiological changes that are happening. 13 to 15 years is the vulnerable group. Females, gender and sexual minorities, because that is when gender identity is still emerging. Elevated pain tolerance, ineffective stress coping, difficult temperament, psychiatric comorbidity, and then various kinds of psychological processes which are directly important because there is no sure diagnostic methods which can unearth it. It is our psychological tools, including observation, thorough clinical history, testing, which could be tapping into this particular phenomena. And most importantly, as Dr. Rupesh was mentioning it, NSSI does not necessarily happen always in vacuum. It is always in reaction to the family situation. So the psychosocial, particularly the family variables, become very important, which model we know based on, though we'll be heading into subspecialties of clinical psychology or health or whatever, fundamentally we need to remain, we should not lose touch base with our theories, because whatever that we are doing, application part is deeply rooted in the theory. The learning theory basically says that for every behavior there is a function, it serves the function, therefore it is maintaining it. So therefore, what is the function of the NSSI? That it helps the person to manage the emotions which are stirred because of certain situation. And then in that process, it can lead to sometime the reinforcement could be internal or external, because depending on the situation, how it is involving. So therefore, one of our assessment goals would be to understand the level of regulation that is there, whether it is autonomic, it is serving the social function, or the types of reinforcement, positive or negative. And another one is 7 functions model, which has identified that this particular behavior serves 7 functions, which we need to keep in mind. There are several etiological models. Thankfully, they're all coming from psychological and social. What it says that there are some people who engage in NSSI might be doing that as a compensating strategy, or it is a maladaptation for relational as well as regulatory functions. That is in real life that they are not able to manage certain situation. As a result, at some point of time, NSSI will come as an adaptive behavior. And sometimes we all know that life will have some are, though it's a cliche to say that we'll have stressors, but we all, that is true, real, and we all will have this capacity to manage the stress. And some people may not have this kind of experiencing of the pain. So NSS will give them some kind of experiential avoidance. And likewise, ruminations can lead to negative effect, leading to escalated emotional dysregulation. Therefore, maladaptive behavior like NSSI, or sometimes there is a crisscross or conflict or interaction between intra as well as interpersonal factors, motivation, volition. Sometimes people might not completely under their own influence of the decisions and choices that they make. And very importantly, across these theories will come is emotional dysregulation and powerful benefits. Otherwise, I cannot communicate my distress. So NSS will give a platform. So that's another thing. And lastly, multifactorial things could be there. And how do we understand in young adults or adolescents that there are distal stressors, proximal stressors, and in between there are internal as well as external factors are interacting with each other, then leading to NSSI related vulnerabilities will perpetuate. At some point of time, we'll be seeing NSSI. Now, what are the implications of these two psychotherapy? Any psychotherapy, not specific to NSSI, will have two arms. One is the assessment part, the second one is the therapy part. Assessment is all the theories are talking about different psychological, social factors in the context of a biological makeup, genetic and non-genetic factor. How do we understand these factors? So a thorough assessment is needed. Literature is very clearly talking about when you do a comprehensive assessment, that itself will help stakeholders, including the person who is resorting to NSSI, the families, other service providers, to identify these are the triggers, these are the maintaining factors. Then sometime even the common sense or our own psychological awareness of how to deal with these issues can mitigate the problem. And there are two kinds of assessments that have been pointed out in systematic reviews. One is the psychosocial assessment based on all the factors that I've highlighted, and also the therapeutic, that is the stressors, trauma, the kind of issues that are going both internally as externally. And how do we come to an understanding of the formulations, either it could be behavioral, attachment basis, or any other theoretical thing, and that will pave a way to set appropriate goals. And intervention per se, though I'll be talking about various kinds of intervention model, they all are drawing heavily from CBT, DBT component. So learning theories and the DBT components, particularly the stress tolerance and emotional regulation, being mindfulness. So these are the things. MBT is mindful based therapies, and other interventions are also somatic based. Interventions are coming up now, and more evidence is required. In this context, what are the specific psychotherapeutic modalities that are available to us? That is developmental group psychotherapy, therapeutic assessment, emotional regulation, individual therapy for adolescents, intensive contextual treatment, cutting down program, which my colleague Dr. Oshin is going to talk about. What is our research at NIMHANS? What are the findings that we got? And more studies are going under Dr. Rupesh, treatment for self-injurious behavior. And as mental health professionals will be looking at what is the evidence. Just because they are there doesn't mean that they are really helpful. Among all these theories, one of the criticism is only the CDP and TSIB have the randomized control trials, which means the highest level of evidence is there. For the remaining thing, it is, the evidence is at a much lower level. And finally, what the studies are indicating is that no particular therapeutic approach is superior, has greater effectiveness as compared to the other one. So therefore, I'm just presenting the therapeutic modalities here in the background, which has RCT. So accordingly, depending on our own orientation, practicalities, you can select your name one of them. And developmental group therapy, as I said, the component is from CBT and DBT. It predominantly focuses on relationships, school problem, because there are adolescents after all, peer relationship, depression and self-harm, because depression and self-harm, the correlation is very high, hopelessness, feelings about the future, like how optimistic they are, because we know that lack of hope or futuristic orientation can either mediate depression and then NSSI, or independently can trigger NSSI. So therefore, it is quite natural to understand why these components are focused. Therapeutic assessment would focus on very highly, solution targeted, like what are the target behavior, how do we enhance the motivation for change and exploring the potential achievers. Some of you might wonder that why we really need to talk about motivation for change when somebody is brought or voluntarily coming for some kind of therapy. My colleague Ocean will tell you later that it's very difficult terrain to really work with them, because the challenges, the ambivalence to really work on, and the triggers will be ongoing. So sometimes the motivation to change things could be quite low. Not that they do not want, the external circumstances could be such that. And cutting down program is a manualized CBT and has some component from DBT, but it's heavily a CBT model. And we know when I'm talking about CBT, the basic premise is that event being the same, how a person has come to interpret an event and what kind of maladaptive pattern leading to maladaptive coping mechanism at emotional and behavioral level, and how do we change that by understanding the triggers. So in this context, promoting the knowledge and identifying the triggers, alternate coping mechanism, and consolidation of learning and stabilizing. So here again, it is individual, and some family component also could be involved. Emotional regulation, on the other contrary, it is behavioral skills are taught, heavily drawn from DBT. And here, the not only an SSI, it also focuses on other destructive behavior. Particularly, this will be useful that NSSI is seen in the context of cluster B personality, emerging traits, or other high risk taking behaviors are there. Then perhaps this could be one of the better option. And treatment for self-injurious behavior, I will not go into details. And intensive contextual treatment, you can see that all the variations are that, in terms of whether it is individualized or the family component is there, or what are the basic therapeutic goals, how many sessions are there, how long it is to be given, it is manualized or it is more in person. And one of them also has an online training program. So this is where the formats will change. Now coming to cutting down program, there are 4 modules given across, and they're all quite flexible. And these models are 8 to 12 sessions, and sometime up to 16 sessions we can go up there. And the first module is getting started. As it happens in any CBT, we would like to understand the client motivation for therapy, therapeutic alliance, and then a collaborative case formulation, as it happens in CBT, that the person need to be involved in understanding what triggers, what maintains it. And then the next level, next module will look at the interlink between thoughts, behavior, and action, what is known as chain analysis. And here basically we look at the triggers, moderators, mediators, etc. And then we consolidate this formulation. And before you ask, already module 1 is talking about formulation. Why the second module? Because it also talks about ongoing formulations. And the third one is coping, that there are programs to address the emotion, distress tolerance, problem solving, mindfulness, and interpersonal effectiveness, because which are the key critical psychological factors that maintain an SSI. And the last one is that how do we stabilize the person, and also have preventive relapse prevention also is a component of it. In conclusion, NSSI, it is explained through multimodal factors. Therefore, our assessment also need to focus so extensively. One, and most therapies that are existing, they draw from CBT and bit of DBT components. No single therapeutic approach is sufficient or adequate or superior than the rest of the thing. A central focus of current therapies, this is where our capacity as individual therapist is very important, because that considering anything that we need to combine emotional regulation, the trauma, relationship quality, sense of loss, and risk-taking behavior, how we interweave all these factors, whatever may be our theoretical orientation, and what kind of strategies we'll be bringing in. But it is up to us, our ability, capacity, how we can combine all these elements and detect in a given case and then integrate them. And this, no matter whether it is CBT or DBT, the factors which are important are collaborative therapeutic relationship, motivation to change, that is client factors are very important, and directly focusing on the NSSI behavior, and gradually dwell more deeper into what are the psychosocial factors that will be maintaining is what will be giving us answers for therapeutic approach for NSSI management. Thank you all.
Thank you so much, Dr. Thomas. So nice for keeping up the time. Again, we'll try and take the questions at the end now, please.
It's working. A very good afternoon to everyone. My name is Dr. Oshin. I'll be giving the third talk. I hope I'm audible. Yeah, okay. So now that we've established a foundation about what non-suicidal self-injury is, it's a very diverse, multifaceted phenomena with diverse etiologies, factors that lead to it, the manifestation, which is the methods that the individuals use, and the functions served by the self-harm behavior. So there is a very diverse range of patients that would come with NSSI, and the management has to be tailored for it. So now we've also established that there is no one superior treatment for NSSI. CBT, cognitive behavior therapy, and dialectical behavior therapy have some evidence because they work on one of the important functions that is presented, for example, emotion regulation. In my talk, I'll be talking about the process of therapy or what goes on as helpful factors in therapy, whatever modality is used. The focus will be based on my PhD study where a CBT approach was used. So the title of the talk is Effectiveness of Psychotherapy for Management of NSSI Among Adolescents, Therapist Reflections on Therapeutic Alliance, Process of Psychotherapy, and Challenges. All right. So this is something that we've already covered, what NSSI is and how diverse a condition it is. DBT and CBT have some evidence. Some other therapies, including mentalization-based therapy, IPT, interpersonal psychotherapy, are also efficacious, but there's no one well-established treatment. When we look at non-specific factors, the factors that are not related to the therapeutic modality, not the techniques, but the factors in therapy room, for example, the client factors, the patient factors, or the therapist factors, or the alliance. Those are the non-specific factors that bring about the change or that are related to the process of psychotherapy or how it is helping. So motivation for therapy and perceptions of psychotherapy are two important factors here. So I'll be talking about what we found in my PhD during my PhD study. To give you a foundation, I'll start with certain basics of what the main findings were, and then I'll go on to the non-specific factors. So we wanted to see the effectiveness of one psychotherapy, which is a manual-based cognitive behavior therapy. It's called the Cutting Down Program, to see the effectiveness in reducing frequency and intensity of NSSI acts and NSSI urges among adolescents, and to see the association of non-specific factors, which is patient motivation and patient perceptions of therapy with the outcome. So this was the overall flow chart of the study. Out of 52 adolescents, 30 completed the intervention, out of which 5 were interviewed for in-depth to understand their experiences in more details. And that is what I'll focus more on today. So we've already gotten an overview of the Cutting Down program. It has 4 modules, and which is what we used in the study. These are some worksheets in the program. In the initial phase, you try to elicit the functions, the nature of self-harm, and then you go on to the middle phase where you give them some strategies, and then you move on to relapse prevention by consolidating the gains with the coping tree or the first aid kit. So these are some worksheets, but and techniques that are used in the intervention. So in the social demographics, majority of the sample out of those 30 were females, and a small portion were 13.3% were males. The mean age was 15.9 years, and they were mostly from an urban or a semi-urban background. They had a diverse range of psychiatric diagnosis, including depression, anxiety, OCD, and PTSD, and others. And in terms of methods, as Rupesh sir had mentioned, there can be diverse methods, which was also the case in our study. Cutting and hitting were most frequent. The most common function of self-harm was to stop bad feelings, which is related to emotion regulation, to stop feeling bad. So one of the reasons that adolescents give while hurt, that they shared with me in therapy sessions would be that they would want to, the pain of self-harm would be such a strong stimulus that it would distract them from their emotional pain. So it would help in emotion regulation in that manner. So this is something that we found in our study. In terms of response to therapy in this particular study, about 50% of adolescents showed response, which was defined as at least 50% reduction in the acts after the end of the intervention. And this was maintained for 43% after 3 months at a follow-up. So there was a significant difference in NSSI acts after 8 weeks of therapy, but there was no significant difference in the NSSI urges after therapy. So the acts reduced, they stopped self-harming, but they continued to report urges. This was the main finding. The screen is a bit cut off from the end, but in terms of non-specific factors in the quantitative findings, we found that there was a positive correlation, small but positive correlation with patients' perception of therapy and their which was the component of problem actuation and the improvement that happened. This means that the more they encountered their interpersonal problems in the therapy room and were able to work through it with the therapist, the more improvement they saw later. Similarly, there was a negative small correlation with a form of motivation, external motivation, and the improvement that happened. This means that even though individuals improved after therapy and the changes were less, they continued to be motivated, which means that they were very self-driven and they wanted to work on their issues despite the self-harm coming down. They were continue with therapy. They were motivated to continue with therapy. In terms of the qualitative results, this is the structure of the interview that we followed. We elicited details or asked questions about the effectiveness of therapy, what techniques were useful, not useful, what was the mechanism of change, how the change happened, and about the therapeutic alliance and termination. So these were the 3 important themes that came out from interpretative thematic phenomenological analysis: contextual factors, recovery from self-harm, which is the what of psychotherapy, that what helped in psychotherapy that the self-harm reduced or improved, the non-specific factors, that how the change happened, and all of these things happened in a context. So I'll talk about each of these factors separately. In terms of recovery from self-harm, adolescents reported that enhanced coping skills, so the tools and techniques that they learned, how to use alternatives of self-harm, how to regulate emotions, how to engage with some other negative replacement behaviors or cope in a different way, helped. Environmental modification helped, changing the environment in a way that they were able to deal better with the triggers, and the aversive consequences of self-harm itself was a deterrent. So for example, one of the adolescents told me that the aftermath of after hurting herself would be to clean up with first aid, which was such a tiring task that she just felt like not self-harming. So some aspects about the self-harm itself or how the parents would react would become a deterrent. So these 3 factors helped in improvement. In terms of non-specific factors, therapist factors, patient factors, and the alliance were important. There were certain challenges and termination-related issues that I'll also discuss. In terms of the context, the child or adolescent was influenced by the parent-child interaction, the immediate home environment, the school environment, and the cultural setting that they were in. So these were the themes that were elicited. Like I mentioned, enhanced coping skills included replacement behaviors, emotion regulation skills, cognitive restructuring, mindfulness, and other techniques. I've already talked about this. This is a tabular representation of the same. So I'll share some excerpts from the adolescents. So one of the adolescents said, "I tried to make the place more positive by doing a hair care routine instead, and my brain would think, like, you take care of yourself in this space, so it's weird to cut here." So whatever the usual place was where she was hurting herself, she changed the association that she had with that place. So external modification happened in this way. Or I just got tired of it. It's like a lot of work cleaning the wounds and then, not disturbing the healing process. Like I itch a lot after that, the self-harm itself being a deterrent. In terms of the therapist factors, the therapist attitude, skills, and values were helpful. Patient factors, when they were open to disclose about their self-harm, when they were open in therapy sessions, when they were motivated to work on it and saw it as a problem, and when their needs and expectations were aligned with what the therapy goals were, it was helpful. In terms of therapeutic alliance, some of the adolescents reported that it was a safe space to express their emotions freely. In terms of termination, some adolescents reported that certain elements of terminations were difficult transitioning to another therapist, because a lot of adolescents were actually handed over to continue therapy to work on other goals after self-harm had improved. So that is something that was also discussed in the interview. In terms of challenges, there were a lot of practical and interpersonal challenges that were reported. So I'll just skim through this. I will share some excerpts. So consistency helped me become better. I have been coming for sessions and continuously doing what I was told to do. I keep trying to practice them. So this is a patient factor that helped. It's a non-specific factor, but the consistency or adherence to the therapy sessions, following up with the homework is something that was helpful. There was a little more freedom of speech and feelings in therapy. So I think that really helped me, because I couldn't keep a lot of things bottled up anymore. The last one, I think the termination was definitely something that I struggled with a little bit, but I think I understood also like that was a necessary part of how this relationship worked. In the contextual factors, positive parenting practices, negative parenting practices, parental attitude, parental mental health were all important. In socio-occupational or school environment, academic stress, relationship with peers and teachers was important. In cultural factors, religious beliefs and practices and mental health stigma were important. So one adolescent said, like, school was just probably why it got so bad. Once I graduated out, it was way better. So once that stressor reducing also helped in her recovery, is what she said. This is also quite important. I didn't want everyone else to know that I wanted to continue with therapy. I also think it has also got to do a bit with my mom constantly telling me that I should not be telling people that I go to therapy. It's not that she's completely embarrassed about it or thinks it's something not good. I don't know why she says that, but sometimes it's kind of like an offhanded comment about why did you tell people? So this is the parental factor influencing the outcome in therapy.
Oshin, yeah.
Yeah. So to conclude, therapy was effective in reducing the NSSI acts and not urges in this particular study, but the non-specific factors have come out to be very important factors in considering whichever therapy modality is used. They actually quite play a significant role in the outcome of therapy. So that is what I would like to conclude with. In the Indian context, there are more interpersonal aspects that are coming out to be relevant, and the method is also something that is slightly different from the Western context, which is what I like to highlight.
Thank you so much. Dr. Rupesh, can you please come up and the dice? Quickly, there was a question for Dr. Rupesh from, yeah, please. Dr. Rupesh.
Thank you everyone. Nothing something basic so that it is also very now this thing where they would create a WhatsApp group and they share with each other that I'm also doing it also do. Now the other therapy modalities that we use is there. But with this particular thing, any specific, any practical that you can share, that how do we work on this where there is so much social validation for them doing self-harm. So how as therapists we can we cannot certainly change their friends or their group and it is like a mass thing. So is there any practical strategy you have used or come across if you can share? Thank you.
I think the therapy one.
Yeah, anyone?
I asked Oshin to respond because we are aware of such WhatsApp groups and.
Oshin, I think you answer. Oshin will take your. Yeah.
I just want to say that that's a very relevant question. Social contagion is actually a very, very important factor that leads to more self-harm behavior among the peers. I think to intervene, I can think of discussing this with the adolescent directly in the session, involving the parents in the loop about how the interaction with the peers is influencing them. Having a talk about this openly with the adolescent, because sometimes from the WhatsApp group, it may seem that as if they are promoting this behavior among each other, which is certainly something that could be happening. But a lot of times they go to these groups for support. So how can that be replaced by something healthier? Is something that we could explore and look at.
Thank you. Yeah, please.
I don't know the issue as well that they have to they come up the same time and perform the same act. But what are the chances that it will delay or decrease the likelihood to perform the act? Because it might provide them a social emotional support which they need. So it might also decrease or delay the action.
Literature has identified equivocal findings for that one. Some people will go with the aim of getting validated, there the needs are met, they stop it. Some people might find that it's something done now, by the peer group. They might get more involved in do that, or they might end up thinking that this is the only way of managing the emotional dysregulation. Okay, and therefore, collectively as mental health professionals, we need to engage with the current technology to send the messages and also to reach out to train the mental health professionals. And one of the things that we still do that is that the other person whom you are reaching out also at the same age, they might be understanding you, but beyond the point they cannot, give you solutions. So why don't you come and talk? And that's where we'll be again identifying what are the barriers, why they're not able to look out, internal resources or within the familial resources, or maybe professionals like us and address those barriers. Is the way. And finally, I don't think we can have complete control on this one. Awareness, continuous dialogue is the only thing that we have to be hopeful of.
Just add to whatever is said. So one of the thing is group doing group and all. It's usually you see in the initial part and the mid level of the work, you're starting therapy or mid level work. So once you are again as whatever you asked about again validation. So that usually, for example, helping benefit might come later. So these people are really for example, therapy would have started or before, or something going on or not fully achieved. Some of the issues are still unresolved. And also, for example, parental issues, very significant negative parenting practices. And again, they have mental health issues, significant depression, anxiety. So these people respond a little late compared to people who don't have this. So these sometimes end up in these kind of group and doing perfectly. Sometimes it's also rebellious against the parents and the system as such. So that's all goes. So again, the associate behavioral problems, psychiatric problems, you see.
Thank you. Yes, please.
Good afternoon, sir. I had a question for Thomas, sir. Thank you so much for such an enlightening presentation to all the three delegates. Sir, you were telling about the assessments that could be used. Given the literature and how DSM-5 tries to identify NSSI or parasuicide, there is a difficulty in identifying the frequency threshold, like when to consider whether it is clinically concerning. So can you just tell us a little about when do we consider it to be a little more, addressing it with a proper module like cutting down program or something like that?
That's a very tricky question to answer. I just would like to begin with the DSM-5 position itself, that it has not recognized this under the mainstream diagnostic entity, but a kind of clinical phenomena that is of clinical significance, number one. No? Number two, we cannot wait for how many number of acts should be, should serve as a threshold or lethal or anything. As it applies to any behavior and understanding, as abnormal or normal, several criteria we apply, right? Age is one, the purpose is another one, learning, whether it is really serving the goal or not, is it adaptive, socio-cultural, from any angle, we can talk about. And we cannot apply only one criteria and say, make decisions about to take it up for therapy or not. For example, psychological distress may not be there in most of the adolescents or people who commit NSSI. It is rather the other person who would have identified. And if we say, but most psychiatric disorders, say OCD, anxiety, psychological distress is quite a prominent criteria. And if you only go by that, we'll be missing out. So rather, we can bring in multiple dimensions and also sometimes looking at the long-term repercussion, how do we make an informed decision? Sometimes the family and the child also may not be really convinced that they need management. We have such experiences collectively where we explain to them that, look, you need to come for a short stay, or you need to come for inpatient admission, so we can understand what's going on, not necessarily that there is some kind of condition. So this should explain to you that we cannot really approach this as from a diagnostic phenomenon, number one. And number two, that is the reason transdiagnostic approaches are also highly emphasized in the management of an SSA. So considering all these factors, you can make a decision as a clinician about it. And there are certain rating scales which I'll hand it over to Ocean, including which he has used in our thesis and Dr. Rotation.
So, as so rightly said, the assessment has to be covering a lot of aspects: the diagnosis, the function, the method used, the severity and frequency, like you mentioned. There is one tool, there is a very small tool, clinician rated severity by the APA. So that can be used to rate the severity of NSSI. But at the same time, if there's very low severity of NSSI and the child or adolescent is suicidal, the intensity of the intervention will obviously be very urgent and intensive. So the decision has to be based on a lot of factors. There are many other tools which can be easily found on literature which focus on these domains.
Nothing much they already asked. Like, for example, DS already, I put up DSM putting in the conditions of interest. So in future, they're going to consider, they as of now, it says like five instances of five cutting, or for example, any NSSI aspect in a year, past year. So as of now, this is the like one of the criteria. Might be there, might not be there in the future, depending on when they might say 6 months, 1 year, more number of. So it depends upon when do they come up next time.
Ma'am, I just had one follow-up question regarding what Thomas sir said. Since you mentioned that early identification becomes difficult because their clinical presentations may be delayed, you also talked about how OC traits might also be involved and how distress is shown in such disorders. Let's say because of such delayed presentation, this behavior becomes a compulsion. So in such a scenario, how important does it become to ascertain the intent? Like, do we do the work on intent since we are using a mindfulness-based paradigm?
Absolutely. Absolutely. To answer and concur with you, we need to understand intention, number one. Number two is that even when the only problem is if you take a very fixed approach that intent has to be there, most of the time in a clinical setting, we see people who did not intend to harm, but the act itself has result in with lethal consequences. No, one. And if you combine the entire research on suicide as well as NSSI, they are identifying two psychological transdiagnostic factors. One is the cognitive inflexibility and emotional dysregulation, which if we can take a developmental trajectory, identify at the earliest, we may or may not see always NSSI, but target these two. At least some kind of protection is happening, not necessarily from NSSI, even other psychiatric or psychological morbidity.
Thank you, sir.
Yes, please. Yeah.
Is that to point of view where when we define time looking class there is very destruction about many ways the conceptions it was clear and there's no intent to time. But when I was clear what I'm noticing is somehow I feel that definition was become something that I was noticing was she said when I'm having this urge and they're very fine clothes and I start eating chocolates. I go drink a very, very cold water and I go and take a very, very hot shower in English convention. So somewhere I feel the definition doesn't encompasses the way people actually try to harm themselves without intending to harm society. So somewhere I feel is there scope for me to say that?
You can in terms of presentation wise, there are wide varieties of presentation. So that's again here whatever you mentioned is again she dresses up all those aspects. As of now again I cannot say why she does it because I don't have first-hand information and other things. Thinking is like a lot of cognitions and one ways of doing it and ways of for example reasons maybe like she's doing it in terms of something important or aligned some small aspect we all know, little pain, little pleasure. So that aspect, so if you have more information, I'll be able to tell this very less information. So that's all.
I agree with you. I agree with you that definition is incomplete, perhaps we also need to bring both suicidal intention and unintention both into the diagnosis to capture, because the theory which I presented, based on the literature, that it is in the continuum. Sometimes the acts not necessarily be there. Even the urge, based on urge also can we identify NSSI. Because in her study, what we found out is that the acts have come down, but there is a strong urge, which we know as mental health professional, it can anytime explode, right? So in case if I say acts are not there, then I will not be doing anything. Even how are we going to work on the urge? But I'm not the right person to say how the conceptualization has to be there. I agree with you that current conceptualization is not right.
Just one last add-on service that her description for doing this is my way of resisting myself from doing this. Because if I don't do this, I will end up doing wrong. So this is my way of trying to reach it. So I feel this is also part of it.
Literature identified that as a protective mechanism against suicide and dissociative experiences.
As you can see that the yes, please. This is the last question, please.
Oh, yes, thank you. My name is Priyanka. I'm a clinical psychologist from Guwahati, Assam. I had really appreciated the point that you mentioned that after 8 weeks of intervention, the acts of self-harm had reduced. And my query is regarding to a population of late adolescents or early adults within the framework of doing DBT with cases. Yes, the acts of self-harm, it reduces the motivation to continue therapy so high. They are so much into proactive behavior, self-preserving mechanisms and such. But the urges, they keep coming back, or it takes so much longer. What more we can do as therapists, or how longer it can take? If you have any kind of a work on that, aspect, if you can just highlight.
Any one of you, please.
Yes, yes.
Thank you. That's a very relevant point. In fact, now is to understand why this finding came and why the urges still were continuing. I was reading about what kind of interventions can be helpful to address the urges, since they have they can be strong. So what I read was that prolonged exposure can help in addressing the urges better, which is something that is not feasible in a short intervention like 8 to 12 weeks of therapy. So any So, for example, whatever the triggers or whatever the situations that probably trigger their emotional dysregulation, negative thoughts, which precedes the self-harm behavior, exposure to those situations. Prolonged exposure to all the triggers is something that I was reading about, but it was not very feasible. There is a component of exposure in the cutting down program as well, but there was a preference and focus on more short-term interventions or immediate solutions, like what alternatives they can use or how they can engage in distress tolerance.
Can we take it up later on?
Desensitizing the thing?
Yeah.
Okay, all right, yes.
Maybe no, is that okay? Yeah. So everybody, as you can see, all three of them have given a very lucid presentation and excellent symposium. Thank you so much. One last thing that I want to ask you. As you can see, the generations are changing every 5 years. We have a very, very strong family network. Students or children are not wanting to use that anymore. So I just want to know one thing, which is what is the difference between the child and adolescent mental health and different approaches that they are using in India versus internationally? Do you think it's the same? Are they actually using? No.
They are not the same. First, in terms of what constitutes as NSSI, what are the approaches, everything, and the informal and formal support, the way mental support itself in India, in child and adolescents across the country, family is an integral part of our services. Unlike in the West, child is completely, no matter what the age, they are completely, put in an isolated setting, and the treatment is given rather than the management and understanding the overall holistic factors. I'll stop.
That'll be all. And I think we close this session here. Thank you so much for your presence. And we were wondering if we'll have the hall full, and it is indeed. Thank you so much for your presence. And thank you for your question. And thank you all of you.
Thank you all the speakers and chairperson and the participants for this wonderful discussions. Thank you. Good evening, everyone, and a very warm welcome to all present here. We are starting on time, which is a very good thing, I think. We are delighted to have you with us for symposium titled Autism Spectrum Disorder: Bridging Gaps in Awareness, Assessment and Intervention. The session aims to shed light on challenges, advancement in understanding autism from early awareness and diagnosis to effective intervention and inclusion. It brings together perspectives from academia, research, and clinical practice to help bridge the gaps that still remain in the care continuum. It is my absolute honor to introduce the esteemed chairperson for the session. I would like to welcome Dr. D. Vijay Raghavan, sir, clinical and social psychologist come tutor in the Department of Psychiatry at JIPMER, Puducherry. His key areas of interest, sir, please come to the dais. His key areas of interest include child psychology, neuropsychology, and group therapy. He is an active member of several professional bodies, including the State Mental Health Authority of Puducherry, the Rehabilitation Council of India, and Clinical Psychology Society of India. He is also a professional life member of both the Indian Association of Clinical Psychologists and the Tamil Nadu Association of Clinical Psychologists. I welcome you, sir. Now I would like to call our speakers to the dais. Our first speaker of the day is Dr. Nilam Kumari, Assistant Professor in Psychology at Mandar College, Ranchi University. Ma'am holds a PhD in Clinical Psychology from Rinpas, Ranchi, and has worked in the Child Development Department of the Jharkhand government. Her areas of interest include neurocognitive assessment and rehabilitation, schizophrenia, and childhood psychology. She has several publications and paper presentations in reputed national and international journals and conferences. I welcome you, ma'am. Please applause. Our next speaker, Ms. Abha Mishra, a RCI licensed clinical psychologist in private practice. I welcome you, ma'am. Ma'am holds an MPhil in medical and social psychology from Rinpas, Ranchi University. She has previously worked as a clinical psychologist at the Air Force Communication Center, Gurgaon, and as a student well-being and behavior counselor in schools. Her primary areas of expertise are child and adolescent psychology, and she has presented papers at both national and international conferences. Welcome, ma'am. Our final speaker for the session is Dr. Indu Solanki, a RCI licensed clinical psychologist and assistant professor at Ranchi Institute of Neuropsychiatry and Allied Sciences. She holds an MPhil and PhD in clinical psychology from Rinpas. Ma'am is a life member of Somatic Ink Blot Society and a co-opted member of the Board of Studies at Sri Rawatpura Sarkar University, Raipur. Her work integrates academic scholarship with deep clinical engagement, particularly in psychological assessment and interventions. We are honored to have her with us today. I welcome you all, ma'am. Please continue. Just, sir, felicitation. After that, sir, you can start the session. Okay. Now, I would like to request Dr. Kirti to felicitate our chairperson. Please. Yes. Now, I would like to request sir to felicitate our three speakers one by one. Please, sir. Come. Yes, yes, ma'am. Please give the student. Requesting sir to open the session. Thank you.
So good afternoon to all. I welcome you for the session on ASD, and I congratulate the speaker to choose this topic. And hello. So good afternoon to all. I hereby thank the organizing committee to give me a chance to chair a session on a wonderful topic, which is very need nowadays to create the awareness and interpretation. So here we have 55 minutes from now. We can divide the session into 3 parts. Okay, each person can take 15 minutes to, and last 10 minutes can keep for a discussion. Okay, just I welcome you to present.
Good evening, everyone. The topic of our today's symposium is Autism Spectrum Disorder, Bridging Gaps in Assessment, Awareness and Intervention. I would be dealing with the awareness part, and assessment and intervention part would be discussed by my co-presentees. My presentation is broadly classified into 3 categories, dealing with the introduction of autism, autism in Indian scenario, and bridging the gap. So to start with the introduction of autism. Autism spectrum disorder, as we all know, is a neurodevelopmental condition characterized by persistent deficits in social communication and interaction and repetitive restrictive patterns of behavior, interest, or activities with significant individual differences and complex etiology. Now the question is why the term spectrum is used in it. Spectrum in ASD indicates that each individual is affected in different ways, from mild social impairment to severe deficits in communication and behavioral pattern, often with overlapping comorbidities. So these are the 3 basic or key symptoms of autism: challenges with social skills, challenges with communication, and restrictive or repetitive behavior and interest. If we have a look at the history of autism briefly, it started in 1799 when Dr. Jean-Marc Gaspard Ettard, without naming the term autism, described the symptoms of autism. The term autism was first used by a Swiss psychiatrist, Eugen Bleuler, in 1911, which comes from a Greek word auto, meaning self, and ismos, meaning action. In the 1940s, 2 researchers, Dr. Leo Kanner, described about 11 children with early infantile autism in his paper, and Dr. Hans Asperger's described children with normal early language development but difficulties with social interaction and intense focused interest in his paper. And in 1981, the latest work was termed as Asperger syndrome by Dr. Lorna Wing. Now, if we talk about the history of autism in India, it was described in the Indian scientific literature in the very same year of 1944 of Kanner's and Asperger's publication by a Viennese pediatrician, A. Ronald, without using the term autism. The term autism appeared in Indian literature in 1959, followed by half a dozen research publications in subsequent years. The main source of information about autism in the late 1970s came from parents and professionals who were involved with a broader field of disability, and awareness of autism among professionals grew during early 1980s. Now, from the late 1980s through today, autism in India has experienced an intense period of activity relative to the previous decades. Now, going through the history of diagnosis of autism, it was not recognized as a condition in the first two editions of DSM published by American Psychiatric Association in 1952 and 1968. And children with autistic trait were considered as the cases of childhood schizophrenia. DSM-3 first described the condition of infantile autism as a distinct diagnosis under the category of pervasive developmental disorder. Further, in 1994, DSM-4 expanded the categories of PDDs to include autistic disorder, Asperger disorder, Rett disorder, and PDD-NOS, and underlined the classical triad symptom as deficits in social interaction and communication and restrictive repetitive behavior. And a major shift was brought in 2013 when DSM-5 clubbed all the earlier descriptions under one category of ASD and reduced the symptoms as persistent deficits in social communication and interaction and repetitive restricted patterns of interest and behavior. Now, ICD 11th revision, which came in 2022, did the same clubbing and underlined the two set of core features similar to DSM-5. Now, if we have a look about the Indian scenario of autism, then according to the WHO, in 2021, it reported that worldwide 1 in 127 persons had autism. But this estimate is an average figure and reported prevalence differs substantially across studies. Specifically in India, 1 in 65 children between the age group of 2 to 9 are affected by ASD, according to an epidemiological study conducted in 2014. And according to the Indian Journal of Pediatrics 2021, it is 1 in 68. Earlier, ASD was known to be higher in males, having a male-female ratio of 4:1, but over the last decade, the gap is narrowing. There has been a worldwide increasing trend in the cases of ASD over the last decades, which can be attributed to increased awareness of the condition and better screening and diagnostic tools, clubbing all the previous categories into ASD in DSM-5 and reduced stigma. Of course, technology is also playing a role in the diagnosis. Now, despite all the progress made in India in context of diagnosis and management of autism spectrum disorder, several challenges still persist. Like expertise in ASD diagnosis and management are more concentrated in urban centers, creating rural-urban divide. In India, autism is diagnosed often late, between 3 to 5 years, and sometimes even much later. The Right to Education Act mandates inclusive education. Many mainstream schools lack the basic facilities for the same, like lack of special educators, sensory-friendly classrooms, IEPs, or even children with autism are denied admission or placed in special schools. Private therapy centers are quite expensive for a common man, and it costs anywhere from 10,000 to 50,000 per month. Employment opportunities for persons affected with ASD are also minimal. If we have a brief look about the challenges faced by parents, there are many. ASD has an intense lifelong effect on the children with autism as well as his or her family. The impact of deficits not only affects the child's interaction with his family, but also affect the relationship of the family with the community. For a parent, accepting a diagnosis of ASD is a challenge, and raising a child with autism is a new challenge every day. Now, if we come to the main crux of today's topic, how to bridge the gap between all the challenges we have just discussed about, specifically in Indian scenario. So I will make you aware of all briefly about the government policies and legal protections in context of autism spectrum disorder. As we all are aware, the RPWD Act 2016 has recognized autism as a disability, and individuals with autism have every right to education, healthcare, and employment. Now, National Trust has also launched several schemes for the benefit of children with special need, which include autism also. Samagra Shiksha Abhiyan, which is a central sponsored scheme, also has a provision of inclusive education of all children with special needs from pre-primary to senior secondary level, which is facilitated by resource teachers or special educators. Now, these are some of the schemes which are launched by National Trust for children with special needs under the age of 12 years belonging to autism, cerebral palsy, mental retardation, and multiple disabilities. Niramya is an affordable health insurance scheme for all age group. Disha is an early intervention and school readiness scheme for the age of 0 to 10 years. Vikas daycare scheme is for 10 plus years of age. Samarth is residential care facilities for all age group. Gharonda are centers for lifelong shelter and care. The details about these schemes, like the eligibility to apply, are available on the official website of National Trust. Now, another major milestone was from the Government of India by issuing the guidelines for certification of autism for the first time on 26th April 2016, using the tools like Inclane and ESA, which will be discussed in the next part of the presentation by my co-presentee. I just mentioned about the Samagra Shiksha Abhiyan, which is a centrally sponsored scheme. The part of inclusive education in Samagra Shiksha Abhiyan is taken care by special educators or resource teachers. You might not have heard the term Block Resource Center. I would like to focus on it. Block Resource Centers serve as a dedicated resource center offering essential therapy-based intervention to support the physical, cognitive, and communicative needs of children with special needs, which include occupational therapy, physiotherapy, speech therapy, psychological, and behavioral support. Now, who works in the block resource centers? They are staffed with trained resource persons, special educators, and therapists who work closely with parents, teachers, and caregivers to create personalized intervention plans for children. Apart from providing inclusive education, an annual camp is also organized by the BRC for the identification of children with special needs. These are the picture of Block Resource Center Namkum. This is how a block resource center look like. And here the special educator is working with children with special need, which might be with autism or mental retardation or multiple disabilities, and trying to make them learn things. Children living in the remote areas can access these resource centers at least twice in a week. Special educators are available, and the availability of occupational therapist, speech therapist is a bit questionable, especially in the remote areas, but as per requirement, they can be facilitated. Now, another major initiative, which is mobile app, you might be aware of, its name is Prashast. It is very important. Prashast app stands for Pre-Assessment Holistic Screening Tool, which is a revolutionary disability screening tool designed to identify and support every child's unique need and thus empowering inclusive education in school. Now, how it works? The key features of this app are, it is a comprehensive screening tool which cover all the 21 disabilities as per RPDW Act 2016. It is a user-friendly mobile application which generates school-level reports for authorities. It is of great help for school teachers, principals, and special educators. Now, another important step in this direction is cross-disability early intervention centers. Department of Empowerment of Persons with Disabilities on 17 June 2021 has launched a single window cross-disability early intervention centers in its various national institutes and CRCs to give focused attention to children in the age bracket of 0 to 6 years of age. Such centers are equipped to provide the following services: screening and identification, facilities for identification of risk cases, referring for appropriate rehabilitative services, therapeutic services like speech therapy, occupational therapy, and physiotherapy, counseling, which includes parental counseling, peer counseling, and school readiness, which include communication and language development, physical development, personal, social, and emotional development. So there are more than 20 cross disability early intervention centers, which works under 9 national institutes as shown in this slide. And this is the Composite Regional Center, which is situated in Namkum, Ranchi, the place from where I come. And I visited this center, and there is the availability of special educator, occupational therapist, and speech therapist at such centers. Now, if you ask like how a person who is having a child with autism or any other children with special need, how he can go to this place. So first step is if there is a screening, and if he is diagnosed with some condition, mental health condition, then and the detailed assessment will be done. Then his disability certificate, which is called UDID, would be made. And on the basis of that UDID, he can avail the services of CRC without cost, free of cost. So the Special Education Department of CRC classifies the children with special needs as intellectual disability, autism, learning disability, slow learner, ADHD, multiple disability, children delay in developmental milestone, and other disabilities. And these are the services provided by the CRCs, which I have already discussed briefly. Now, you might be aware that 2nd April is celebrated or declared as World Autism Awareness Day by the United Nations General Assembly. And this year, in 2025, the theme was Advancing Neurodiversity and the UN Sustainable Development Goals, which highlights the intersection between neurodiversity and global sustainability efforts. On the same day, according to a report issued by Press Wind Up. Okay. The Ministry of Education also reaffirms that block resource centers and Sarva Shiksha Abhiyan should be used for the maximum benefit of individuals affected with ASD. Caregivers training is another important aspect for children with autism. And WHO, along with the international partners, has developed a 5-part package on caregiver skill training for families of children with developmental delays or disabilities. Now coming to the most important part, role of media in today's age. So the popular print, electronic, and now the social media has its major role in spreading awareness and acceptance of autism in India. And it has a history which goes back to 1988. A movie called Rain Man, which many of you might have seen, is based on a person having autism with Savant syndrome. So it brought autism to the consciousness of certain sections of the population of India, just as it did in many other countries. So these are a few of the movies, picks up few movies which are based on cases of autism. You might have seen some of them. If not, then you can now. Anyone of you have seen serial Aapki Antara? You might be very small when it was released. It was a serial based on a 5-year-old autistic child called Antara, which featured on Zee TV. And it brought a lot of awareness in the society about autism. And according to a study, the impact of that popular serial, just concluding, sir. The impact of this popular serial was that during initial months, almost there was a day when 336 calls came in a week inquiring about the condition of autism. So we can imagine if the television can have that huge impact, how we can use the social media for spreading awareness. So these are some of the official institutes, websites working for autism, basically Autism Speaks, Action for Autism, Autism Society, India Autism Center, and the National Trust. Thank you.
So, good evening, everyone. I want to thank Dr. Neelam for the awareness. And I think you have got a lot of information about what currently going on in our country regarding autism. I will be taking the part on the assessment of autism. So, the tool used to screen and diagnose ASD include checklist, standard checklist, behavioral observation, as well as comprehensive diagnostic interview schedule. So, accurate assessment guide individual training program and improve outcome for the individual with ASD. Let's start with the early screening tool. It is very important to screen a child as early as possible for the proper management. So few of the tools are modified checklist for autism in toddlers, which we can administer to the child of age group between 16 to 30 months. It is a two-step screening test. The first part is for the parent and the second part is for the staff along with the parent. Then we have screening tool for autism in toddler and young children, STAT, which is for 24 to 35 months. It can administer, which is done in 12 different tasks, which include play, communication, imitation ability, and it takes around 20 minutes to perform this task. Then the third one is ages and stages. It is administered on child as young as 6 months to 5 years. The parents are the primary caregiver should fill out the general developmental screening tool, and it consists of 19 age-related questions, developmental questions on 19 developmental category, which comprise of gross motor, fine motor, communication, problem solving, and adaptive skill. Then we have Trivandrum Autism Behavioral Checklist, TABC, for 2 to 6 year of children. It sees the 4 major domain of social interaction, communication, behavioral trait, and sensory integration. It also helped to classify autism according to the severity, which scores from 20 to 44 and more. The more the score, the severity is the more with the children of autism. Then we have communication and symbolic behavioral scale developmental profile. It is also administered as young as 6 months to 24 months. It has 3 components. The first component is a checklist completed by parents. If the first component is not successful or not been done, the clinician administer the other 2 components, which is follow-up caregiver questionnaire and behavioral sample, which is taken from the child during the interaction. Other screening tool include social communication questionnaire, autism behavioral checklist, parent evaluation developmental status, Indian autism screening questionnaire, and Chandigarh autism screening instrument. So after screening, when a child is considered as a positive or at a high risk, they undergo evaluation with the diagnostic tool to confirm the diagnosis of autism. But before that, a formal assessment of hearing, vision, cognitive skill, along with complete physical examination is done, which is very crucial for the diagnosis of ASD. So the diagnostic tool includes Autism Diagnostic Observation Schedule, ADOS, and ADOS2 both are available. ADOS2 is currently in use. So in every module, the child is evaluated on the proper age of the language and development, such as in one model, when the child who is pre-verbal, who has limited verbal language skill, and the other for the children who are not so verbally fluent. So it is also an interactive tool. So through interaction, a clinician can get more aware about the situation of the ADHD with the child. Then we have autism diagnostic interview revise so this by this tool we can diagnose children as well as adults with autism. It has 3 main key domain which we assess, include restricted and repetitive stereotype pattern behavior, communication, language, and reciprocal social contact. Then we have childhood autism rating scale, CARS, which is very famous in India too. Okay, it is actually a behavioral rating scale, and it is most frequently used with a toddler of age as old as 2 years. Then we have Gillian Autism Rating Scale, GARS. By using this scale, schools, parents, and a medical professional can detect and diagnose autistic children between the age of 3 to 22 years, and also can assign the ADHD severity of the child or the adult. With the children, we have other few tools for the assessment of adult-specific autism, adult who are suffering from ADHD. These tools include Adult Asperger Assessment, Ritvo Asperger Diagnostic Scale, RADS SR, Autism Spectrum Questionnaire, AQ10, Adult Repetitive Behavior Questionnaire, Adult Social Behavior Questionnaire, Developmental, Dimensional, and Diagnostic Interview, Adult Version, and Social Responsiveness Scale. These tools are used for the diagnosis of adult with ADHD. So coming back to India, which is actually the main part of this talk, it's like assessment in how we do assessment in India. So the Indian government has presented, as Dr. Neelam has suggested, that there has been a guideline given by the government of India, which suggests two tools for the assessment and diagnosis of ADHD. The number one is Incline Diagnostic Tool for Assessment. It is developed by using DSM-5 criteria created in AIMS. It has two sections, A1 and A2. A1 has three sections, A1A, 1B, and 1C, and A2 has four sections, A2A, 2B, 2C, and 2D. A1 covers all the social communication deficit types of symptoms in ADHD, while section A2, covers the symptom associated with restrictive repetitive behavior, which is one of the core symptoms DSM-5 with a person with ADHD. So the process of scoring and administration of the test take around 45 to 60 minutes, and it is intended to be used by only qualified personnel, and it is predicted on the basis of the history provided by the main caregiver as well as the first-hand observation of the child between the age of 2 and 9 when the clinician is taking the assessment. Then we have Indian Scale of Assessment of Autism, ISA, which is very popular. It is developed by the National Institute of Mental Handicap. It includes screening questions on behavioral patterns, sensory and cognitive abilities, emotion responsiveness, speech and language communication, as well as social interaction reciprocity. It take around 40 to 60 minutes to administer, and it also require a very proper training. It has total 40 items, which has already discussed that it has been divided into 6 different categories. It can be used as a follow-up and certification. The score ranges from 40 to 200, and as the number rises, does the severity of the autism rises. So it is said that all the children with autism spectrum disorder who has been assessed under the age of 6 will be given the disability of 60 to 79%, that is moderate. Children who are 6 or above will be assessed through ISA for the severity, and then they were given the certification according to the severity. And children who are above, these are temporary certificate, and the children who are above 18 years of age, they will be reassessed through ISA, and again they will be provided with a permanent disability certificate. So as we know, ASD also comes with other comorbidity. So as Indian government has given a guideline for the comorbidity, the test they have recommended to use is Malin Intelligence Scale for Indian children for IQ assessment, Wechsler Scale of Children, again for IQ, Binet Kamath for IQ, NEIPID for IQ. Then they have for other comorbidity like anxiety, depression, epilepsy sort of thing, they have ideas, that is Indian Disability and Assessment Scale, to be performed with a diagnostic tool of Incline or ISA. with this diagnostic tool, we have to support along with supplementary tool for the functional assessment of autism. So the functional assessment in autism is important because they offer a comprehensive understanding of individual strength and challenges and need beyond what is the core diagnostic features. And it also guide the clinician in individualizing the holistic support strategy that they are going to plan for the better outcome of the autistic individual. And we have to also assess the child for the sensory profiling. So why do we do sensory profiling? Because it is a systematic assessment on how an individual with autism responds to sensory input across various modalities such as light, sound, taste, smell, balance, and movement and self-awareness. This further will be discussed by my co-presenter, Dr. Indu. So, in my concluding remark, I would say effective autism assessment tool play a vital role in accurate identifying ASD, enabling early and tailored intervention. Continue refinement and culturally sensitive adaptation of these tools ensure they remain relevant and accessible, ultimately fostering better development and social outcome for individual on the spectrum. And thank you for that. I will call upon my next Dr. Indu.
So good afternoon, everybody. My co-presenters have wonderfully discussed about the awareness and assessment, and I'll continue with the strategies for prevention and early intervention in autism spectrum disorder. These will be the subtopics I'm going to cover. I'm skipping this as we already know what is autism. These are some of the features we can see in autism, like in infancy, we can see the child has less eye control. They do not respond to their name. They are not interested in the caregivers. During 2 to 3 years, we can see that suddenly the child is withdrawn or he starts being aggressive without any reason. There is a loss of language skills, which they have already learned before, and they are unable to communicate or they are unable to be social. Sometimes diagnosis can also be made in adulthood, and each of these children have their own pattern of behavior that may be mild or severe. There are trouble learning and lower IQ signs can be seen. Some children also have high IQ. These children can learn quickly but have trouble in communicating and adjusting in social situations. These type of children, the autistic children, they have sensory and behavioral issues. Either they are hypersensitive or they are hyposensitive. They can react strongly to loud noises, or they may not notice loud noises at all. They may be sensitive to busy environment, or they might not notice any type of visual cues. So either they are hypersensitive or they are hyposensitive. They also have problem in sensory integration, motor functioning, and vestibular and proprioceptive processing. Now, why early intervention is important? Early intervention is important because brain plasticity is highest in the early childhood. The critical period is from 1 to 6 years of age. Early supports can improve language, adaptive skills, and social behavior. And if there is delay in diagnosis, that means it is equal to the missed learning opportunities. These are the type of interventions that can be given to autism spectrum disorder. Medical and pharmacological support is there. Behavioral interventions can be given.
Developmental approaches are there. Educational interventions are there. Speech, occupation, and social therapy can be provided, and family and community support can be provided to these children. Medication can be provided for anxiety and hyperactivity. Early intervention is critical for individuals with autism spectrum disorder. The developmental screening, particularly at 9, 18, 24, 30 months of age, help identify early signs of ASD. Applied behavior therapy and other behavior therapies helps in managing challenging behaviors. Speech therapy improves the communication skills. Occupation therapy develops daily living skills and improves sensory processing. Family supports and education is beneficial as parents play a vital role. And comprehensive and individualized approach could be given according to individual specific needs and preferences. Social skill training, community-based activities is preferable for social inclusion. The goals of the intervention to be to improve the communication and social goals, to enhance the cognitive and adaptive functioning, to reduce the challenging behavior, and to promote the independence and quality of life. Now coming to behavioral intervention, applied behavior analysis and pivotal response training, these are some types of behavioral intervention. They both focuses on observable behavior, on changing the observable behavior. Discrete trial training and natural environment teaching under the applied behavior analysis. They both teaches social communications, academic and daily living skills. Discrete trial training is it is based on instruction, response, and consequence. It is a structured training technique, and here learning is done by the method of task analysis by distributing the complex task in smaller steps. Natural environment teaching is a child-initiated learning in a natural setting. Here, child chooses his or her own activity. Rewards are related to the task and the chosen toy which the child has chosen. Like if a child is indicating or he's showing gestures or he's trying to ask for a ball, then he will be given the ball, whatever he's asking for. That is a natural reinforcement. Pivotal response training is also a natural training. It helps in developing essential skills. It targets the pivotal behaviors that affects many areas. Those key pivotal areas are like motivation, the willingness of the child to do something, self-initiation, initiating his own play, responses to multiple cues, like telling him to bring a big blue ball, like here shape is also there, color is also there, and self-regulation. Here the child learns self-management along with interaction, enjoying the activities. Now coming to developmental approaches. Developmental approaches focuses on emotional and relational development, helping children builds a social connections and communication through play. Some of the principles of DIR is supporting the child's emotional and social milestones, recognizing child's sensory issues, motor abilities, and way of processing the world. And it is relationship-based. It is learned through warm, nurturing relationship. Early Start Denver model is for children from 12 to 48 months. It is a natural play-based training. It focuses on early communication, imitation, and play skills using the natural routines. It integrates applied behavior analysis and developmental psychology both. Natural and social reinforcements are provided in this training. It is different from ABA technique because it emphasizes developmental and joint attention. And in this type of training, parents play a crucial role. Coming to educational interventions, individualized education program is a formal plan for children with disabilities in a school setting. It recognizes that every child processes the words differently. Either he may be or she may be hyper. Here, the structured teaching is done using the visual supports, predictable routines, and inclusive education. Speech therapy enhances communication by demonstrating correct speech, imitation, and reinforcement. Occupational therapy improves the sensory processing, motor, and daily living skills, and social skill training teaches understanding of social cues and relationships. For family and community support programs, parental training programs are there, support groups are there, and collaboration between professional caregivers and educations are done. Medical and pharmacological support can be for anxiety, anxious children, for ADHD, irritability, and sleep disturbance. Now, Blank et al. In 2021, he implemented TIPA-T. You can see his study over there, in which the first step was exchange and developmental therapy, the principles of which was severity, availability, and reciprocity. It is done in a bare room with minimal furnitures because many of furnitures can make the child distract the child. Toys are offered one by one in a predefined order to focus attention. Organization of the room is flexible. Relaxation activities are proposed. A perceptual sequence is there that helps the child to notice, orient, and then respond. Motor sequencing like reaching, eye gazing, gestures, showing gestures, non-verbal social interactions are enforced in the children. It focuses on emotional connections, shared attention, and turn-taking. Environmental manipulation can be done for autistic children. It involves changing the aspects of the surrounding like physical space, lighting, noise, routines, and social expectations. The types of modifications can be like using noise-canceling headphones or ear defenders for the noisy environment, installing sound-absorbing materials, avoiding loud noises, using soft, natural lightings, removing irritable clothing textures in front of them, offering preferred texture for seating, bedding, or clothing, maintaining consistent, comfortable temperatures, and avoiding strong odors. For physical and space layout, clear visual boundaries should be incorporated. Materials should be clearly labeled and organized. Safe, low stimulus spaces should be provided to them. And furniture layout should be such that supports easy movements and avoid crowding. For visual environment and communication support, visual schedules should be used. First, then boards should be provided, like pehle ye kar lete hain, fir we'll do this thing. Drawers, shelves, and bins should be labeled properly. Visual rules should be posted, like for making him quiet, we can use like, please keep quiet. For social and emotional environment, routines should be predictable. It should be kept predictable. Advanced warnings of transitions should be provided, and it is very necessary. Choices and control should be allowed. It is also allowed to build autonomy in them. Calm communication should be encouraged. Now, coming to some of the researches, Muhammad Al-Baltagi in 2024, he reviewed 316 studies that indicated that while dietary interventions and nutritional supplements may offer benefits in managing specific symptoms, the effectiveness of these approaches can vary. Behavioral interventions like gradual exposure and positive reinforcement promises to improve food acceptance, and collaborative efforts among healthcare can provide, it is essential to optimize the autistic nutritional health and feeding practices. Simple decision-making model, like the principle of which is like safe, structured, and supportive. Here, safety means see if they are doing any safe things for themselves and others. If they are in any unsafe activity, then you can step in immediately and redirect to safe alternative. And if they are in a safe activity, then you can move to the next step. No need to stop them. For structured choices, you can ask like, can I give them options instead of a total control? For autistic children, total control is not good. Like instead of asking, what do you want to eat? It can be asked, do you prefer rice or chapati? Means we have to not give the full control, we have to give them options. For supportive encouragement, like ask to oneself, which of the activity is doing? Is there an opportunity for skill building? If there is an opportunity, like if he's keeping the toys in a line, so you can take it as an opportunity. You can enter to that game and like sometimes he's putting his toys, sometimes you are putting his toys, so he can learn turn taking. Sensory responsiveness, this gradual exposure, desensitization, or sensory stimuli is triggered in a very controlled, mild way, and then gradually the intensity or complexity is increased according to the built tolerance, which helps to reduce the sensory over responsiveness. Sensory diet is important for autistic children. Sensory diet provides right type and amounts of sensory experience or balanced sensory input for optimal functioning that matches the sensory needs of the child, whether they are over responsiveness or under responsiveness. This improves attention, mood, and participation in daily activities. Like for proprioceptive activities like pushing and pulling heavy objects, wall push-ups, animal walks, and deep pressure hugs can be done. For vestibular activities, swinging is good, rocking in rocking chair, jumping in the trampoline, riding bicycle scooters is good. For tactile activities, playing with sands, finger paintings, water play, using fidget toys and stress balls is beneficial for them. For auditory activities, listening to calm rhythmic music, using noise cancelling headphones, listening to nature sounds is beneficial. And for visual activities, using dim lights, watching calm lights are beneficial. For oral motor activities, chewing gum can be dangerous also. So chewy tubes can be used. Blowing bubbles or whistles helps in oral motor activities, and drinking thick liquids through straw helps them. For olfactory activities, preferred scents can be used. Now coming to prevention, according to Leo et al., taking folic acids may prevent autism in offspring. According to a study, it may prevent the autism in offspring. According to Gardner et al., maternal immune activation hypothesis posits that maternal conditions associated with inflammations during pregnancy may increase the risk of autism in the offspring. When coming to healthy lifestyle, regular checkup, balanced diet, and exercise, either they can prevent or not. Then there are studies done by Nakara et al. In 2022. In his study, it was found that in mothers with higher physical activities levels during pregnancy, the risk of ratio for autism spectrum disorder in the 3-year-old infants were lower. In contrast, too short or too long sleep duration during pregnancy were associated with high risk ratios of ASD. Emerging evidences suggest prenatal diet play a role in causes of autism spectrum disorder, according to Zhong et al. 36 studies from 9 countries stated higher or moderate intake of prenatal multivitamin, folic acid, and vitamin D. It was associated with reduction of odds of ASD. When talking about the avoiding drugs and alcohol use, it was seen, according to Singer et al., he concluded that no adverse association between low-level alcohol exposure. There were no adverse association was seen between low-level alcohol and ASD. And Sato et al., he indicated pathogenic role of prenatal exposure to valproic acid and maternal inflammation in the development of ASD. Hypersensitive disorders of pregnancy and advanced parental age increases risk of ASD in humans. So concluding, we can say that early support and access to services can make lifelong differences. Ongoing research into genetic, environmental, and neurobiological factors enhances understanding and guide preventional strategies. Early identification and intervention are key to improve the developmental outcome and quality of life for individuals with ASD. And multidisciplinary approaches, they provide an effective support for ASD. And family involvement and community awareness are crucial in reducing stigma for ASD. So this, I'm concluding. Thank you.
You get that for the introduction to the second one is about the third one is about the there are many important things about thinking just go with that. Again, well, the questions are low. So we can.
Genetic part is very important. A lot of European studies have mentioned that neurodegenerative problem happens before the sperms are not stronger enough.
But the studies that you have quoted here is all about the pregnancy of the mother. So it's quite, extreme part of it. But a lot of studies says sperms that are there doesn't carry healthy, offsprings. They are already having a degenerative illness in them. But here you're only mentioning the mothers. So it's quite.
Okay. And there were no cases which I saw. The mother being stressful to pregnancy and the offspring was diversity. And in both cases, the environmental factors, I cannot say about the genetic factors. If truly, I say I did not go on time.
Yeah, I think we are missing out a bigger chunk of it because it's not just the during the pregnancy, it's already before the what it is, the lifestyle.
If the father is related to maybe the level ASD, but there's no surety. I mean, there's no clear cut finding till yet. And genetic factor still, people say it is related. It is maybe need the development of ASD. But again, there is no genetic finding still. What is it? The genome, what is it?
Genomics.
Genomics still not clearly concerned DNA, cancer, whichever is creating that ASD wala issues.
Not specific. None of the genomics can specify which illness can be coming to the offsprings.
Then the 18th for ASD. It is still not clear. But they are her father had advanced, just gone to one study, is the age of the father may cause because the quality of sperms get deteriorated. So may again may be the reason for the development of ASD. This must be not sure.
Not just for ASD, but other neurodegenerative. Yeah, okay.
I appreciate the audience also mentioned the importance of father and not only putting the sole burden on their mother. Thank you for highlighting that. So I just have two questions. One is about recently, it's been seen, like I'm a clinical psychologist, and we have seen that there are adults who come with first-time diagnosis for autism. So it's quite hard because we don't have history. The parents are not able to recall the childhood development. So how do you see the assessment? Like definitely we understand it's going to be a permanent disability card, but how do you see that? That's one question. Second one is about the use of identity. So in research language as well as in normal, the way we are speaking now, we say autistic child or autistic adult. So how do you see the use of terminologies of person with autism or autistic child? Where should the identity be? Should the person be given importance or the diagnosis? Because there's still debate going on who should be given importance on the terminological use. So that's the two questions. And thank you so much. It was a session which was within the time limit and really appreciate that. Thank you.
First coming, first question. Was later, diagnosed with the ASD in 100%. So there may be misdiagnosis in the driver, which may be one of the reason. Second reason, they have learned masking, they have masked themselves, so the symptoms were not seen clearly, and when they were significant, then they were not hospital was there. So this may be there because sometimes they are misdiagnosed like with ADHD or personality disorder or anxiety problems. So this is the reason they are not diagnosed in the childhood. Once again, please repeat the second question.
Actually, if the person is an adult and his what is there for informal way, the functional, high functional adult, autistic person, it is sometimes their choice whether they want to call it person with autism or autistic person. It is there. But again, if it's a child, it's dependent on the parents. depend on them, whatever they got.
As you know, as you asked, it's about everything. Everything child is. Of course, we as a professional, we need to be label the child. That is not the intention as a professional to label them. It's not a compulsory thing, but we have to know what is the diagnosis and how we are going to treat the child. So at least if you are not going to turn the curve as autism or ADHD with parent, but you have to engineer the parent. That is the child is having some problem. So you can tell the parent that the child is having these are the problems, these are the symptoms of disorder. So it should be treated. At least you have that type of communication if you can, but parents should know what the child suffers. They could not say, they could not misunderstood that it is normal only. The child used to play better time because they never see it is hyperactive. They will be saying they will play flat. So there is different between that and this. So that differential color should be explained to the parents. Then only they will be interested to take the child to the. So otherwise, in any case, we are not here to label anything or anyone that should be paid. That should be the parents should be have a pay that someone able to any type of. So in that case, we as a professional, we have to be with that. How effectively that can be effective. So here we have finished the question session and also congratulate the three speakers and for the order. Thank you very much.
Thank you so much. Thank you, ma'am, for this wonderful presentations. Thank you all our participants for this discussion, and thank you, sir, for chairing the session. Thank you. CRE questions will be circulated in the group in a while, and you may fill it up. Okay. Thank you. Track-3 is also one of the national products.